Hello everyone. The topic for today is asthma. It's a critical topic in respiratory medicine. I'm sure you would have likely covered many of its important sections through various sources. I'm going to take up the discussion on the most crucial points that are covered in Harrison's. Let us start the discussion with epidemiology. You should note that asthma is the most prevalent chronic disease worldwide and is likely seen in urban areas and is a disease of industrialized nations. It can occur at any age, and currently with the treatment, mortality rate although is declining, but the prevalence is currently increasing. Asthma pathogenesis is extremely complex, and it includes the combination of environmental exposures that occur in a genetically susceptible individual. Asthma is characterized by four important hallmarks, which includes reversible bronchoconstriction, airway inflammation, airway hyperresponsiveness, along with airway remodeling, which adds an irreversible component to this disease. With continued exposure, along with exposure to variety of triggers, leads to disease progression along with asthma exacerbations. There is a comprehensive list of various exposures that are linked to the development of asthma covered in Harrison's. I will give a brief overview of the most important points that are covered in it. You should note that allergen exposures, they are the most common causes, and they generally include inhalation of indoor pollen, which is generally seasonal in nature, and thus thunderstorm asthma is the name attributed to it. Along with that, dust, molds, cockroaches, and indoor animals are likely important etiologies. And occupational exposures, remember, they can be of two types. Either they can cause an irritative type of disease, which is referred to as reactive airway dysfunction syndrome. This generally will heal completely and not give rise to asthma, whereas the immunologic variety leads to sensitization in the individual and is linked with asthma. This is referred to as occupational asthma. Along with that, air pollution, the most important agents that are implicated include carbon monoxide and nitrogen dioxide exposure. Infections including respiratory syncytial virus and rhinovirus along with mycoplasma infections are contributory to asthma. Tobacco smoking is one of the most acquired and preventable causes of asthma. Along with that, it has been proposed that vitamin D deficiency predisposes to asthma. Along with that, vitamin C, E, zinc, and polyunsaturated fatty acid supplementation is deemed to be protective. Causative factors in prenatal exposures include use of H2 blockers or PPI, acetaminophen. Along with that, maternal smoking is also contributory. It can increase the risk of asthma in and the infant. Along with that, you should note that hormonal exposures throughout life can exacerbate as well as precipitate asthma, which includes pregnancy, menses, and menopause. Along with that, you should note that apart from these exposures, the disease expression is generally manifested by a variety of triggers. There is a lot of overlap between the variety of exposures and the triggers, that includes like allergens, irritants, and infections, which again remain the most common etiologies. Apart from this, you should note that exercise and cold air exposure contributes as a trigger to asthma. Along with that, air pollution and drugs, which includes beta blockers, ACE inhibitors, and aspirin are important etiologies for triggering asthma exacerbations. Aspirin gives rise to a special variety of disease referred to as aspirin exacerbated respiratory disease, which is characterized by nasal polyposis and sinusitis. Along with that, there is asthma in the individual. The pathogenesis is linked to the chronic inhibition of COX pathway that will give rise to the unhindered increase in the LOX pathway and thus increase in leukotrienes that will mediate asthma, that will mediate airway inflammation and contribute to asthma. The treatment for this condition is to limit the use of NSAIDs as well as aspirin, but you can also go with COX-2 inhibitors or acetaminophen because they do not inhibit the COX or the LOX pathway respectively. You can also use leukotriene modifiers and biologic therapy, and if chronic administration of this drug is necessary for individual, then aspirin desensitization can be attempted. You should note that asthma as a disease is extremely complex, and it generally manifests in two important phenotypes, which includes extrinsic or atopic variety and the intrinsic and non-atopic variety. In the atopic variety, the disease is generally mediated by Th2 cells, and thus there is an eosinophilic inflammation with increase in IgE. The disease is generally not severe and manifests in childhood. It is more common in males as compared to females. You should note that it is associated with atopy, and thus allergic rhinosinusitis or atopic dermatitis will generally be seen in the individual, but this is never related to food allergies. This is an important point to note. Along with that, the mediators are generally linked to eosinophilic inflammation like interleukin 4, interleukin 5, or eotaxin, and the prognosis for this disease is excellent, and it is responsive to currently available standards of therapy. Whereas non-atopic variety of asthma is generally mediated by Th1 cells. It is extremely severe. It is having neutrophilic inflammation component with normal levels of IgE. It is generally associated with infections and occupational exposures and occurs in adulthood, and it is more prevalent in females. This disease is mediated by mediators of acute inflammation, and it is unresponsive to current standards of therapy, though it might be responsive to macrolides. This is the basic description of this asthma pathogenesis. You should read the textbook for more insight. Let us start the discussion on the approach to asthma. You should first note that the differential diagnosis for asthma is broad, and you should include CHF, allergic bronchopulmonary aspergillosis, COPD, inducible laryngeal dysfunction, also referred to as vocal cord dysfunction, are important etiologies to remember. Bronchiolitis obliterans and pulmonary infiltrates with eosinophilia, which includes eosinophilic granulomatosis with polyangiitis or Church-Strauss syndrome, or acute eosinophilic pneumonia, chronic eosinophilic pneumonia, which are covered in chapter number 288, which will be a subsequent discussion. But these are important differential of asthma to keep in mind. Apart from that, the general diagnostic approach is elicited by a classic history of asthma, in which there is an episodic cough along with shortness of breath that is labeled as or described by the patient as chest tightness along with wheezing and mucus production. Detailed history must elicit triggers in the individual. So you should ask for whether the patient smokes or not, and what type of exposures can occur likely in the home environment, in the work, through recreational exposure. Are there any seasonal symptoms that can be mediated through travel, or if the patient has some important drugs or is currently on drugs like aspirin or ACE inhibitors or beta blockers, which can exacerbate this disease. So you should keep in mind all this. Remember, physical examination in asthma is generally normal, except for the case of asthma exacerbation. There is a whole lot of battery of tests that you can go for to confirm your diagnosis, which includes but is not limited to first pulmonary function testing, in which will generally reveal the FEV1 by FVC ratio of less than 0.7, and reversibility is generally demonstrated. This is defined as the FEV1 increase of greater than equals to 12% or absolute increase in volume of 200 ml after 15 minutes of bronchodilator administration. You can go with flow volume loop measurements, which will show scalloping, and the peak expiratory flow rate will be reduced. Also, diurnal peak flow variability will be greater than 20%. On lung volume measurements, you will see that the TLC and residual volume is increased. If it's a Th2 mediated inflammation and thus eosinophils are increased, generally the eosinophilic inflammation will lead to increased NO production, and thus the exhaled breath condensate, okay, that is the fraction of expired nitric oxide will be increased to values of greater than 35 to 40 parts per billion. Along with that, it will also cause an increase in the diffusion lung capacity for carbon monoxide. You should also note that you can test for airway hyperresponsiveness through the methacholine, that is a bronchoprovocative testing. You can also go with mannitol or hypertonic saline if a methacholine is not available. The interpretation of this test is basically based on measuring FEV1 decline of more than 20%. This is referred to as provocative dose at 20%. It should be less than equals to 400 microgram. That is airway hyperresponsiveness. The less dose should trigger bronchoconstriction in the affected individual, whereas such a small dose will generally not elicit inflammation. It will not generally elicit bronchoconstriction in a patient who is not suffering from asthma. Along with that, you should note that you can go with a variety of testing that includes testing for allergy in these patients, which can include increase in eosinophil counts in the person, along with that increased IgE, radioallergosorbent testing, along with a specific test for AVPA. You can also go with skin testing, which includes PAS testing or intradermal testing. You can also demonstrate an increase in peripheral eosinophilia. Pathologically, sputum will generally reveal Kirschmann spiral screwula bodies, Charcot-Leyden crystals, and also mucus plugging of airways can be seen. There is a new investigation that we have currently. This is referred to as noble gas MR. So in noble gas MR, we generally use the radio labeled helium, and this is a type of ventilation scan. In the healthy lung, you will see a bright blue colored lung that is not having any ventilation defect. But in patients who are suffering from obstructive disease, there will be some areas which are left underventilated, and this generally reveals an obstructive disease in the patient. This is a new investigation. for asthma. Then we come to treatment of asthma. Treatment of asthma is currently according to the GINA guidelines, which change very frequently, and thus you need to stay abreast of the most recent update for GINA. But in short, you should note that it includes the components of assessment, adjustment, and review. So you have to assess for comorbidities, you should assess for inhaler technique and whether the disease is controlled or not. So you will ask for whether the symptoms are there or not for asthma. You should test for inhaler technique because it's the most common cause for severe asthma, that is poor control of asthma. Along with that, comorbidities which can make difficult asthma control include these variety of diseases that are listed in Harrison's. Read the textbook on your own to get insight on these various diseases. Then you should note that you have to always review lung function at every visit. Along with that, you should ask whether exacerbations have occurred or not, and what are the you should review side effects of the medications that you might have prescribed, and you should review vaccination in these people. So you should remember that asthma people, because respiratory infections are a major cause for morbidity in these people, you should go with vaccination, including pneumococcal vaccines and influenza vaccines, along with COVID-19 vaccines. This can likely prevent the exacerbation in the individual. Along with that, the goals of asthma therapy generally are related to less than or equals to 2 symptom frequencies. Along with that, nighttime awakenings should be less than 2 times per month. Reliever use should be less than 2 times in 1 week, and they should be less than 2 exacerbations per year. These are the most important standards for the goals of asthma therapy. The treatment is a stepwise approach. You will first ask for symptoms. The most important change in that current guideline standard is that in step 1 and step 2, that is when the disease is intermittent, that is less than 2 episodes of asthma exacerbations are there per month, or if the disease is mild persistent, that is more than equals to 2 per month but not daily, in that condition controller treatment is not required. Whereas the current standard for reliever therapy is as needed LDICS formoterol and not SABA administration, because frequent SABA use has been correlated with both poor asthma control along with an increase in mortality. So the current standard of therapy is to use LDICS and formoterol combination. For step 3, the symptom severity definition is more than that is occurring on most days. Along with that, they can be night awakening. For this, the treatment is LDICS formoterol. Move up the ladder if the patient also has low lung function, and thus you will use MDICS formoterol. If the patient is not achieving control even on this therapy, this is referred to as severe asthma. In this condition, you have to add on LAMA to MDICS formoterol, and this is referred to as severe asthma. You can also consider HDICS formoterol and various biologic therapies for the patient. You should note that a new drug that has now come into the market, which includes anti-TSLP antibody, that is tezepelumab. Along with that, omalizumab is anti-IG therapy, and other drugs which you can note from this figure. Apart from this, you should note that these 2 important paragraphs are there from in Harrison, which includes the description of asthma in pregnancy. I'll give you a very short review. You should note that asthma in pregnancy can either improve, it can also deteriorate, also it can remain unchanged. The principles of management remain unchanged, but you should avoid triggers, and there is a clear benefit of using inhaled albuterol and ICS for these pregnant females, but you should note that you should not use oral corticosteroids. Along with that, allergen immunotherapy is not recommended for these for pregnant females. Along with that, if prostaglandins are needed to be administered, then you should avoid PGF2 alpha analogs because they are associated with bronchoconstriction. Chronic administration of systemic corticosteroids, that is in the oral or IV form, they are associated with a lot of side effects, and thus it has been said that if the oral prednisone dose is more than 20 mg per day, you should go with pneumocystis pneumonia prophylaxis for this individual. Along with that, because a major side effect also includes osteoporosis, then you should also go with osteoporosis screening in this individual. Apart from that, ICS, obviously because they are the drug of choice, they have resulted in a dramatic reduced side effect as compared to OCS, and the major side effects include a small increase in risk of glaucoma, cataracts. Along with that, they can also be associated with osteoporosis, bruising, and hoarseness of voice, that is due to a myopathic effect. And the major side effect is thrush, which can be reduced using a spacer and gargling in the person. Along with that, you should remember that a treatment of asthma exacerbation is related to first elucidating whether respiratory failure is present in the person or not. So you should go with looking for altered mental status or decrease in heart rate, which is abnormal. Along with that, if the respiratory muscle fatigue is present in the individual, generally there will be an absent pulsus paradoxus along with silent chest and increasing PSCO2 levels in the individual, and paradoxical thoracoabdominal movement, that is during inspiration the abdominal movements will go in, whereas during expiration it will move out. In this condition, you should suspect that the patient is having impending respiratory failure and thus needs invasive mechanical ventilation. The target is to use low respiratory rate and ventilation volume to decrease the peak airway pressures. For the other variety where such type of dangerous life-threatening symptoms are absent, you should consider whether mild to moderate exacerbation exists in the individual or severe exacerbation is present. These are the important differences between the two of them. You can take a snapshot if you want to. The treatment is also written over here. You can take a snapshot if you want to. Just remember that you have to always assess clinical progress and lung function in all patients 1 hour after initial treatment, and the target of treatment is that FEV1 or peak expiratory flow rate should be 60 to 80% of the predicted, whereas SpO2 should increase to more than 94% and symptom resolution should occur. This completes the asthma and the review of asthma. Do read the book. Thank you.